My brother, Professor Dr. Sualiman Almayouf. Professor Sualiman Almayouf is a consultant pediatric rheumatology at King Faisal Specialist Hospital, and he's professor in Medical College at Faisal University. Dr. Almayouf finished his residency training program in King Faisal Specialist Hospital and followed by fellowship in Toronto, Canada. Dr. Almayouf served as a board member of Saudi Rheumatology Association, and he's the national coordinator of the Pediatric Rheumatology International Organization, PRINTO. Dr. Almayouf has more than 120 publications in PubMed scientific journals, and as well many abstracts. He also frequent lecturing and active in the field of pediatric rheumatology, and you are always honored and happy to have him in our program. Dr. Almayouf.
Assalamu alaikum wa rahmatullah. Did you see my slide?
Yes, yes, you can proceed.
The voice is okay. مساء الخير جميعا. First of all, I'd like to thank Dr. Ahmed for his kind invitation and kind introduction. Probably this talk is a bit different from the previous talks. We'll focus on joint rather than extra joint. And I will talk about children. This is my objective or headlines. I will review with you the ILAR classification criteria for GIA as an introduction for the topic. And I will highlight the differential diagnosis of GIA, and probably the second part, which I hope it will be attractive and interesting enough to share cases, just to illustrate the message from this presentation and to know the lessons that we learned from these cases. I believe everyone see this photo, he will consider juvenile arthritis as one of the differential diagnosis, or probably advanced juvenile idiopathic arthritis. But I can assure you this is a case of rare disease known as inherited lipid storage disease, known by name of Farber disease. You don't need to know the details about this disease, but the message you need to recognize inflammatory versus non-inflammatory articular manifestation. So if we go to the basic, just to see the normal joint structure, as you know, there is synovium, bone, muscle, ligaments, and tendon. Any disease affect this structure may lead to disease or joint abnormalities, either in terms of joint swelling, probably pain, maybe overgrowth. So any disease affecting this structure may cause articular disorder. So we have wide spectrum, as you know, of diseases present with musculoskeletal manifestation, or let us more focus articular manifestation, name it, infectious causes, malignancy, autoimmune, autoimmunity, non-inflammatory. All these, it can be one of the diseases present with musculoskeletal manifestation. Mind you, arthritis is not a final diagnosis. All the time we teach our resident, please don't write diagnosis as arthritis. You need to be specific in your diagnosis. As you know, juvenile idiopathic arthritis is the most common childhood chronic inflammatory arthritis. And arthritis is the main clinical findings in these cases. Some of these cases, unfortunately, present late with contractures, deformities, because either they were missed or maybe they don't receive enough medications or proper medications. So they may present to your clinic a bit late with deformities. As you know, juvenile idiopathic arthritis is not a single disease. It is a heterogeneous group of conditions. And this chart showed the different subtypes of GIA. And depends on the referral where you are working, you will see the cases based on the referral pattern. It's important to remember that GIA, we don't have diagnostic tool. It's a diagnosis of exclusion. You need to exclude other conditions before labeling a child with this diagnosis. We used the ILAR classification criteria. It's widely accepted. However, it's under revision, and there will be a new classification criteria, but it's not finalized yet. So I will not discuss the new one. I will just stick to what we are using right now. We have different subtypes: oligoarticular if the child has less than 4 affected joints, polyarticular rheumatoid factor negative, and polyarticular rheumatoid factor positive, which is equivalent to adult RA. And we have also systemic GIA, which is similar to Still's disease in adult. And also we have enthesitis-related arthritis equivalent to SPA in adult, and the psoriatic arthritis similar to what our colleague adult rheumatologist use and treat. Saying that GIA is a diagnosis of exclusion, we need to keep high index of suspicion for other possibility, and what we use to consider certain manifestations, signs, symptoms, and we call it red flags. When it's there, you need to think about other differential diagnosis. Fever, I know fever is part of systemic GIA, but still we need to keep it as red flags. If the child has nighttime pain, which is not usual be seen in GIA patient, this is alarm sign. If the patient has pain out of proportion of the clinical sign, if the child has weight loss, lymphadenopathy, hepatosplenomegaly, again, we need to keep it as red flags. Bone pain, not joint pain, bone pain. And if there is a strong family history, whatever the similar cases or condition, you need to think this is probably not usual or not GIA case. This is a differential diagnosis based on the subtype. I'll just put here oligoarticular, polyarticular, and systemic, and you can see the infection, malignancy, and sometimes trauma or post-traumatic, sometimes bleeding. It may present like if it's only single joint, hemarthrosis or bleeding disorder. Polyarticular, again, we need to think about malignancy, infection, autoimmune disease. SLE may present with arthritis at the beginning, then they develop others. Metabolic condition, genetic, and we will focus more on that. And if the child also have bone dysplasia. Systemic type, probably we need to keep high index of suspicion about malignancy, namely leukemia. And part of our practice, all the time we need to do bone marrow aspiration for all systemic GIA patient before initiating any treatment. As I said, the spectrum is too wide. I will not talk about each, but I will focus more on this category, which is non-inflammatory conditions. I think it's very important to be familiar with these terms. I know people may use it in the same, for the same meaning, but I believe there is some difference and we have to be familiar with that. Arthritis, everybody is familiar. This is inflammation of the joint, but people use arthropathy in case the arthritis is not the usual. I think it's the same like vasculitis, vasculopathy. What is arthropathy? Arthropathy, in my explanation, means abnormal joint. So arthropathy may be present without inflammation. You need to remember and keep it in mind, arthritis is a form of arthropathy. As I told you, based on the joint structure, you may see findings explain or manifest based on the cause. You may see inflammatory effusion. This is probably arthritis, inflammatory arthritis. It may be non-inflammatory effusion. And I will show you cases. They present with big effusion and it's non-inflammatory. The patient may present with thickened synovium. It may be a periarticular tissue thickening or overgrowth of the soft tissue. part of the disease. Maybe the child present with bony dysplasia or overgrowth of the bone. And all these presented like articular abnormalities, and we don't need to stick to one explanation, with i.e. arthritis. If the child has no signs of inflammation, or the lab test not supporting inflammatory process, probably you need to be careful before labeling the child as arthritis. Saying that, I prefer to classify or categorize arthropathy in different types: inflammatory, non-inflammatory. It can be familial, sporadic. It can be syndromic, part of syndromes, or non-syndromic. And also overlap is not uncommon in this condition. You may see familial inflammatory, maybe familial non-inflammatory. You may see syndromic inflammatory arthropathy. I hope the example, the one I will show, may give some idea about these types. Now, already I mentioned some clues, but let me repeat it here. The clues for non-inflammatory arthropathy, or when do we need suspect non-inflammatory arthropathy. If the child presents with musculoskeletal symptoms and there is positive family history of similar condition, you need to think about non-inflammatory arthropathy. If the child has dysmorphic features, I know adult rheumatologists, probably they are not familiar with these. Maybe they just see it rarely, but in pediatrics, we are seeing many cases as dysmorphic features. So we are more familiar with this, terms. If the child has absence of inflammatory sinusitis, i.e. no morning stiffness, I think this is alarm sign. You need to consider non-inflammatory arthropathy. As I said, absence of systemic or synovial inflammation, normal ESR or the synovial fluid didn't show inflammatory cells. Again, this is need to be considered as indicator of non-inflammatory arthropathies. I think it's very important to be familiar with radiological findings. If the child has bone dysplasia, this is not usual seen in GIA, so you have to think about other causes. If the child has long-standing articular manifestation and X-ray showed normal joint space, this is probably, it's not sign of GIA, providing he didn't receive proper treatment. Again, if there is lack of erosions, this is not usual sign of GIA. And of course, ultrasound finding is very helpful in those patients, because in good hands, they may tell you if there is synovitis versus just thickened synovium or other findings. Saying that, it's not uncommon, and I'm talking from personal experience. We are seeing many cases referred to us as GIA, and in reality, these are cases of non-inflammatory arthropathy. Means they were misdiagnosed and unfortunately mistreated and given unnecessarily treatment. So why should we be aware of non-inflammatory arthropathy? I think we have good reasons. I mean, the causes and pathogenesis are different from GIA. Treatment with DMARDs, and I just told you, we have many cases, unfortunately treated with steroid, DMARDs, biologics, which is maybe inappropriate. Of course, the prognosis is completely different, and make proper diagnosis is crucial for genetic counseling, and especially if there is more than one affected members. Since most of the audience are adult rheumatologists, I put this question: why should adult rheumatologists know about non-inflammatory arthropathy? Again, these cases probably overlapped with non-specific inflammatory conditions. So this makes things more complicated, and probably sometimes cases with long-standing articular abnormalities may start to show joint pain, or let us say osteoarthritic manifestations. They may present with pain, and probably people thought this is missed GIA or inflammatory arthritis. And in reality, this is not the case. Cases might be missed and presented in adulthood, and this is not uncommon. Last month, I received 2 calls from patients, relatives, and they just gave me descriptions, send me photos. I will show you similar cases. Unfortunately, was missed. They are adult patients. If there is low penetrance variant pathogenic mutation, probably disease is expressed symptomatically in adulthood. So maybe the first visit to adult rheumatology clinic at that time. And of course, children with confirmed diagnosis reach adulthood and somebody should follow them. And adult rheumatologists should be familiar with these cases. Now, non-inflammatory arthropathy is a descriptive term. It's non-specific diagnosis. We shouldn't accept non-inflammatory arthropathy. Yes, non-inflammatory arthropathy is an umbrella, but you need to come up with specific diagnosis, or maybe you need to consult other services to reach a proper diagnosis. And I found radiologists, good musculoskeletal radiologists, is very helpful to guide you or to support your opinion about the diagnosis. Of course, there is advanced test, we come to it. This will make your life easy to make proper diagnosis. And unfortunately, the frequency of this disorder worldwide is unknown. I know this is very rare cases, but if you make one case proper diagnosis, I think you relieve the family. You will stop patient shopping from one clinic to another. And I think this is very important, and for educational purposes, this is very important to spread this information. This is the first part of my talk. Now I will just make real cases. This is from my clinic cases. The first case, a 5-year-old boy referred with right knee swelling for 2 years. So means the child is suffering for the last 2 years. And you can see there is a difference between the 2 x-rays. There is soft tissue swelling, maybe around the knee and above the knee. And he had intermittent antalgic gait, which is worse with activity. Naproxen was ineffective. In the local hospital, one of the physicians tried to inject because he thought this is juvenile idiopathic arthritis, and he thought probably he will get benefit from local steroid injection. He did that, and it was bloody, so he thought it was traumatic. So he referred the patient to us for probably, because he tried to do it outpatient. So he thought probably in tertiary hospital it will be easy for such procedure. Anyway, when we saw the patient, we took the history. There is no morning stiffness, and yes, he has some pain at the end of the day. And by careful examination, we noticed that he has multiple capillary spots. So we did, as usual, CBC, ESR completely normal. This is, again, it's not unusual to see normal CBC, ESR in post-GIA. I will not put significant weight on these findings, but I think these findings, the skin X-rays and the bloody intervention need to be kept in mind. So we did MRI, and surprisingly, there was significant abnormalities. Of course, we did MRI because we are thought about other differential diagnosis. Namely, you can see the MRI, there is significant neurofibromatosis starting from the back through the hips till reach the knee. And why he has bloody tab or injection? Because there was hemangioma-like, which is associated with the neurofibromatosis. So the MRI, it was consistent with multifocal plexiform neurofibromatosis with increased vascularity. This is the reason he had traumatic tab. And we confirmed that by molecular genetic testing with positive for heterozygous deletion of neurofibromatosis type 1. So this is the case, 5 years old. I came across one case also from our hospital. This is adult patient, 43 years old man diagnosed with neurofibromatosis, known case, but he presented with severe left hip pain. affecting daily activity and limited range of motion. He had limping, positive trend in impaired gait, and the X-ray shows significant right hip disease. And this CT, reconstructed CT, showed distracted hip, and this is related to the neurofibromatosis as well. Case 2, 6 years old boy referred with swelling, contractures. Parents are first-degree cousin, one affected cousin, and you can see this child has swollen hands, contracted fingers, and the X-ray shows severe osteoporosis and contractures everywhere, and probably also there is no carpal bones. So people thought this is advanced arthritic disease or advanced GIA. But if you take careful history, they are family and first degree and affected cousin, similar condition, and he has dysmorphic features. He has nodular lesions in the palms and plantar surfaces. Again, this is not seen in GIA. And the lab, by the way, he has multiple joint involvement. And the lab showed normal CBC, ESR, and RF, anti-CCB, all were negative. So this is a case of inherited multicentric osteolysis. I just go back to the photos. Again, this is, you will see it in GIA patient. I cannot ignore that. But this X-ray, no, you will not see it in GIA. And the findings here, it's not the case of GIA. So inherited multicentric osteolysis, the exact pathogens is not well identified. However, there are different types. There are different types: nodulosis, arthropathy, osteolysis, now syndrome. This syndrome was described from our clinic, and multicentric osteolysis with nephropathy, and also Torg syndrome, Winchester syndrome, and others. And the frequency of these cases worldwide unknown. I mentioned 2 cases last month. I received personal or self-consultation. They have this diagnosis. Unfortunately, it was missed and treated inappropriately with different medications. If you see these X-rays, you will think this is probably arthritis, but again, with proper history, with proper examination, they have this type of disease, which is inherited multicentric osteolysis. I think the clue in these cases, the type of, or the findings in radiological, simple plain X-ray, you will be able to make a diagnosis. Again, typically they have normal inflammatory markers. The radiological findings showed early destructive osteolytic changes of the carpal and tarsal bones. This is typical findings, usually in these areas. And these changes are not consistent with inflammatory arthritis. You will not see it in GIA. We are seeing many cases. GIA, they don't have similar findings. This is what I meant. I don't have photo, but this is what I meant by nodular changes in the palms and the plantar surfaces. These are painless, and we biopsied the earlier cases and showed only fibrotic changes. And it may affect other joints like knees, and in advanced cases, they may have also hip involvement. They have the same X-ray findings. If you see one case, you will see the others almost the same findings. We tried to see if the ultrasound helped in those cases. Yes, we did the like cross-sectional study in these cases, and we found we didn't see any inflammatory changes by ultrasound. And of course, the radiological X-rays, the X-rays is typical for these cases. The most important, the genetic testing. If there is any suspicious or for, counseling, probably you can request the gene test. And in our cases, we found a mutation in MMP2, which is important for balance between bone synthesis and resorption. This is the reason why they ended with osteolysis. The most recent cases we don't use to do gene test unless there is, I mean, either for academic purposes or if the family want to confirm the diagnosis. Otherwise, it's easy to make a diagnosis by clinical findings. Unfortunately, there is no available effective treatment for this disorder, and it's supportive treatment in form of calcium, vitamin D, and we give them also bisphosphonate just to improve the bone density. Case 3, 5-year-old girl presented to the local hospital at the age of 2 years with multiple swelling and limited range of motion. Small, large joint are involved. And again, CBC, ESR are normal, autoantibodies are negative, and the X-ray showed osteopenia and joint effusion. There is big effusion. You can see there is even the soft tissue density. It's mainly due to the synovial fluid. And the most important, the X-ray. This is typical for these cases because this is what we call it coxa vara. And you can see that there is soft tissue and probably there is some contractions. And this patient was seen by pediatric rheumatologist, and he was treated, she was treated intensively with the steroid and biologics, but there was no response. So referred to us for second opinion. And it was very clear from the X-ray and the story of the patient. This is what we call it camptodactyly arthropathy coxa vara pericarditis syndrome, because they have also pericardial thickening. It's not inflammatory. This is non-inflammatory pericarditis or pericardium involvement. This is non-inflammatory and autosomal recessive disorder usually presented early on, and that child has another affected child. So family history is very important. And they have no they have non-inflammatory arthropathy, means they have no morning stiffness, no pain. The radiological findings, as I said, typically they showed coxa vara. And again, in the earlier cases, we tried to do a biopsy, mainly the synovium, and it showed proliferative synovium epithelium, no inflammatory cells. There are cases, and as the disease progresses, you may see in these cases what we call it intraosseous cyst, and this is seen frequently in these cases. And also they have flattened femoral head, and of course they have acute angle, which is coxa vara. So this syndrome, again, we confirm these cases by doing genetic testing. And the first case probably described from our hospital a long time ago. And you can see it was in 1998. There is a gene mutation, mainly in PRG4, which is a surface lubricant. If there is mutation, the synovial fluid will be very thick, and this is the reason they have limited range of motion and fluid collection in the joint space. Probably we described the largest group or cohort in literature from our clinic. This was a long time ago, actually 2013, but we collected more than these cases. Now, unfortunately, the referral diagnosis was inaccurate in all cases, was labeled as GIA. And some of them, they received treatment. So the message here, probably you need to think before labeling a child with GIA, because we agreed GIA is a diagnosis of exclusion. Okay, the case number 4, this is a 12-year-old referred from orthopedic clinic with multiple joint swelling and contractures. And you can see this is a photo of the patient. Parents are first degree cousin, they are healthy. They have healthy siblings, limited range of motion, and affecting the hands, knees, hips, swollen contractures of PIPs. And again, as usual, the CBC inflammatory markers are all normal, autoantibodies are negative. And this is his X-ray in 2014, and this is 2017. And over 3 years, there is progressive changes. The hands, small joints of the hand, also the hips. So the diagnosis, we thought about, this is skeletal dysplasia, and we did the gene test, it was positive for WISP gene, which is diagnostic for progressive pseudo-rheumatoid dysplasia. Unfortunately, this patient was missed for a long time. Of course, it will not make change in his disease course, but at least you will counsel the family, you will tell them the diagnosis, and probably they will be assured and stop seeing different physicians in different places. So the progressive pseudo-rheumatoid dysplasia is autosomal recessive condition characterized by mild spondyloepiphyseal dysplasia. Most of the time they present at age of 3 or preschool age with progressive joint stiffness and bony swelling and absence of signs of inflammation, normal inflammatory markers. As the disease progresses, they start to have narrowing joint space and abnormal contractures and bone overgrowth. And there are, of course, some cases also affecting the spine and ended with spine deformities. Most of these cases are short and they have some dysmorphism as well. Case 5, because the time I will be a bit hurry, 10 years old girl referred from neurologic clinic with the gait difficulties, tiptoe, since a long time. She had some cognitive abnormalities. Parents are first degree cousins. They have 5 siblings, and one child has probably abnormal gait. So she has her balance and coordination as per neurologist was normal, and power tone reflex is normal. She had bilateral knee limited range of motion with big effusions, with limited hip flexions. Normal inflammatory markers, normal CBC, and as per neurologists, they did some studies for brain because of the cognitive abnormalities, all came normal. And ultrasound knees showed effusion with increased signals. So probably there is some inflammatory, but it's not the usual findings. Autoantibodies are negative. We thought with this cognitive abnormalities and arthropathy findings, we need to screen her for possible metabolic disease. And we sent for screening for mucopolysaccharides, and it was this enzyme alpha iduronidase, it was a bit low, which is suggesting mucopolysaccharidosis type 1. So mucopolysaccharidosis, really, it's a group of rare inherited disease, and there are different types. Of course, most of these cases, or the typical scenario to be seen by metabolic genetic clinics because of the severity. However, I think the message here, there is mild cases from mucopolysaccharide type 1 called the shy syndrome. This is probably it's mild, and most of the time, and typically they present with articular manifestations, swollen contractures, and probably it will be missed and labeled as GIA. And shy syndrome presented most of the time preschool at around 5 years of age, and some of these cases probably missed and not considered as a diagnosis until adulthood. And there are case report was missed and found or diagnosed in adulthood. Patients are most of the time are almost normal height. They don't have clear or obvious dysmorphic features, and they don't show intellectual deficiency like severe cases. And sometimes they may have abnormal eye findings in terms of corneal opacification or glaucoma, so they need also to be seen by ophthalmologists. Sometimes also they have hearing defects. They need hearing assessment for neurosensory hearing impairment. Joint contractures is the most obvious manifestation in the mild cases or shy syndrome, and they may present with contractures, deformities, and of course, if there is, depends on the types, but I'm focusing on the mild case or the type, because this is the potential cases to be seen in rheumatologic clinic. Given the clinical heterogeneity and rarity of mucopolysaccharidosis, diagnosis of mild cases not unusual, missed, and the diagnosis was delayed. And there are skeletal findings or X-ray findings typical for these cases called dysostosis multiplex. And this is what I meant by this. And there is abnormal. This is very easy for radiologists to pick it up. And of course, the cases, severe cases may present with contractures and deformities. But typically, they don't have erosions or joint space narrowing. Probably this is the last case, I promise. This is a child referred to our clinic with the right knee swelling. And this is, again, the swelling increased with activity, no morning stiffness. And you can see the swollen right knee comparing to the left knee. And the swelling mainly anterior part. It's not in the back, which is probably you will see it more in the X-rays. And the location is a bit weird. So we thought about other differential diagnosis. And we asked for MRI. I remember one of adult rheumatology fellow, he said, why don't inject the joint? They told him, no, we have to be careful. And I was lucky enough to be right. And the MRI showed hemangioma changes. This is hemangioma. If we stick the knee in the joint, probably it was bloody, and we will think about this is traumatic, and we keep considering the GIA as a differential. So this is hemangioma, not GIA case. So in conclusion, GIA is the most common chronic childhood arthritis. It's a diagnosis of exclusion. Unfortunately, no available diagnostic tool. I think we need to keep high index of suspicion for other condition. Comprehensive history, mainly family history. We need to keep it in mind all the time. And complete physical examination are the most helpful tools in sorting out various causes of articular disorder in children. Non-inflammatory arthropathy should be considered as a differential diagnosis of GIA, particularly with absence of inflammatory manifestation, i.e. clinical and laboratory. I cannot deny advancement in molecular testing have led to identification of Sephiroth syndrome, and if the facility available in your center, your life will be easy. And of course, timely diagnosis of these disorders is crucial to offer the family the proper genetic counseling and avoid inappropriate therapy. At this point, I should thank our colleagues, Dr. Sultan Bahabri, rahimahullah, and Dr. who will really initiate the work of this interest. And I should thank Dr. Abdullah Sumbul, and also our fellows and colleagues from radiology and research center and medical genetic clinics. Thank you very much.
Thank you, Dr. Sualiman, always impressing us with interesting cases, because almost we have a lot of deficiency in pediatric rheumatology all over the countries, as you are always maybe confronted with cases which always consider this scenario in our differential diagnosis. So we can proceed with our questions.
Sure.
So we have a question from Dr. Navid asking about how to play with a steroid dose in active arthritis in children with concern about the growing age.
Well, Dr. Ahmed, I thought this talk for non-GIA, but I will be happy to answer this question. Usually we don't keep steroid. Our aim to avoid using steroid, and one of the landmark of treat to target recommendation to minimize use of steroid as much as you can. Of course, we can use it as a bridge therapy, but ultimately we need to avoid it. And we need to keep, threshold to use DMARDs, either synthetic or biologic, low, depends on the case. And of course, we need to utilize local steroid injection as a modality of treatment. Definitely, systemic steroid, one of the complications is growth retardation in those patients. But the new strategy to avoid using steroid as much as you can.
Yes, we always advise to look for the proper diagnosis first with the pediatric rheumatologist who has the experience to control the dose and when to advance or decrease, which actually beneficial for the patient care, as we are always looking for early pickup of our patients and early intervention, so we can have a beneficial effect to our patient, regardless adult or pediatric. Okay. We have another question from Dr. Higazi asking about malignancy. If there is any suspect of paramalignant syndrome in pediatrics, if there is a specific workup, Dr. Sualiman, you can ask.
I think before doing, I mentioned the red flags. If the child, for example, has fever, unusual pattern, if the child has splenomegaly, if the child has weight loss, pain out of proportion of the clinical manifestations, if the child wake up from sleep because of pain, all these probably you need to consider malignancy as cause for arthritis. And I already mentioned as practice in our clinic, and this is what we teach our fellows and residents. Please don't start treatment, namely steroid, for working diagnosis of systemic GIA until you ask for bone marrow and you get the result. So bone marrow aspiration is one of the important pre-treatment tool.
Okay, so another questions about, it is about idiopathic, it's about the spectrum. If you like to answer, Dr. Sualiman, about the risk.
To be escaped from GIA, because the scope of this talk mimic of GIA, we're talking about other conditions. But of course, the risk factors, namely the type of GIA, post-GIA, girls, preschool age, ANA positive. So this is the most important risk factors for radiopsychology, or let us say uveitis.
Okay, first, this question about mucopolysaccharidosis and the post-PPRD palliative spondylectomy can be seen. Is there any differentiating point on the spine, radiology, or of both?
Yeah, from the clinical manifestation, yes, there is difference. If you are talking about the severe type of mucopolysaccharidosis, as I told, they will not come to rheumatologists. It will be clear and it will be directed to medical genetics. But the mild cases, probably it's difficult. So you need to dig in the history and physical examination. For pseudo-rheumatoid, definitely the type of contractures, they are short, they have disproportion of height. And most of the time we ask for spine X-ray, you will see abnormalities in the spine.
Okay, we have a couple of questions about CACB. Is there any rule for steroids from Dr. Yumna Farag?
Well, I know Dr. Yumna, probably she have some cases, but typically this is non-inflammatory and we don't advise to give steroid. However, in advanced cases, means long-standing, they may have pain and start to show some pain and probably some sinusitis-like picture. And I consider it as secondary because of the chronic synovial thickening and thick synovial. And those patients, probably they may get benefit from symptomatic treatment. I don't advise to give long-term treatment like steroid or DMARDs or these things, because this is non-inflammatory. They will not get benefit from it.
Okay. There's a question about osteochondritis. It's coming from Dr. Mahmoud Said. You're asking about the Osgood-Schlatter and Sieverts
Yeah,
disease.
we are seeing these cases, especially for adolescent athletics playing sports. They may have localized tenderness, and as you know, and all our colleagues, it's very simple by doing X-rays, and the type of pain and the presentation completely different from post-GIA. But it's one of the differential, especially in adolescent age group.
Is there any place to check metabolic profile, hormonals, parathyroid, vitamin D, or whatever, or it's not needed?
For whom?
For this patient, osteochondritis?
We don't see it that frequent. We are seeing Osgood-Schlatter, but we don't see other osteochondritis like adults. But it's not, I mean, we don't do many investigation for those patients. Because
Okay, again,
for Osgood-Schlatter is enough to make a diagnosis.
Yes, and ultrasound also. We are doing ultrasound. Okay, question coming also again for CSCB about any experience in your side in synovectomy for these cases?
Well, we conducted small study, not surgical synovectomy, we conducted medical synovectomy by inject
tetracycline?
Nuclear substance, like, but unfortunately it was not effective, so we stopped that.
Okay.
But
so,
if he asked me if there is any, let us say, surgical intervention in future, mainly we advise them or we link them with orthopedic, probably after they reach the adulthood, they may have some hip arthroplasty. It may help them.
Okay, there's one question about unilateral hip effusion in a glycogen storage disease in a 10 years child with osteoporosis. What is the best strategy to treat?
Well, I'm not sure if it's unilateral. They should look for other explanation, because this is, I mean, a systemic disease. And I would expect to see more than one area. So I would advise to investigate more, but I cannot recommend anything if it's, I mean, with this information. It's unusual to see isolated affected hip or joint.
Okay, what about juvenile osteoporosis, Dr. Sualiman, about your experience in juvenile osteoporosis?
We don't see it much as primary. We don't see them. And I believe most of these cases probably seen by our colleague from endocrine. But of course, secondary or due to underlying chronic disease, we are seeing a lot as part of our patient. And we are seeing from GI clinic, they refer to us patient with Crohn's disease or ulcerative colitis with back pain, and they thought this is spine involvement. Apparently, it's due to compression. Yes. Compression. And because they kept them on high dose of steroid, they don't look in that. So we help them just to draw their attention to this thing. So of course, osteoporosis is one of the complications due to the treatments, i.e. steroid and chronic inflammatory process.
Yes. We have, are you applying also, we have for adults, we have also recommendations for GIO, steroid-induced osteoporosis. We have to submit some medications for protection like bisphosphonates.
Yeah, we are advising to use, we are checking the, of course, the bone profile, vitamin D. If it's in the borderline, we need to treat them. And for those who are on steroid for long term, we supply them with vitamin D. And also we are checking bone mineral density. If it's low than expectation, we may consider bisphosphonate as well.
Okay, there is one question about bisphosphonates. Is there a rule in treating multicentric osteolysis?
Yeah, I mentioned that in my talk. It's supportive. If you catch the patient in early disease course, probably it will slow down that disease progression. It will not stop it. It will just improve the bone density, but it will not change, I mean, the disease nature.
Okay. Another question coming is there any treatment for PPRD?
Unfortunately, no, just supportive. And usually these cases handled by orthopedic, by the way.
Okay, Dr. Navid asking about the intra-articular injection of PRP in children with arthritis.
We tried to apply it, but it was not successful. But yes, it's one of the, we tried with our colleague from musculoskeletal radiologist, but it was not that successful. We stopped doing it.
Okay, one question about the pigmented BVN.
Yeah, of course, it's one of the differential all the time. We consider it, especially if there is isolated joint involvement. We keep it in mind, and we have cases like this.
Okay, by this question, I think we get for the end of your discussion, Dr. Sualiman. We are always happy for this big kind of information and concern to save joints of our children, which is a very hot subject, always missed to diagnose, always overlapped with different diseases. It was really useful, actually, your slides.
الله يعطيك العافية دكتور، تسلم، شكرا.
So